Can I ask Amanda Powell, who's the lead pharmacist for Frailty and the Community Resource Team, to come and speak to us on bone health pharmacy through the patient's journey?
As you can see, there are two of us. I've invited Charlotte Burrows, Charlie, who is one of our clinical pharmacists, along to talk as well. So, covered the screen. So this is the Anand Bevan UHB Clinical Futures Rainbow, which shows the different levels of patient care, with hopefully the aim being that the majority of patient care takes place in that green zone, care closer to home, of course. Pharmacy itself has established services throughout these levels of care, and that involves anything from acute ward pharmacy to community pharmacy on the high street. This gives our profession so many opportunities to influence and affect patient care, including bone health. We already have pharmacist prescribers at ward level who are able to initiate appropriate bone protection at the bedside. Within the community resource teams across Gwent, pharmacy are currently rolling out a service that has grown over the last 5 years with funding from the Regional Integration Fund. We provide a pharmacy service to the Frailty Consultant-led virtual ward rounds, known as the Rapid Medical Service, the Therapy-led Reablement Service, and the Community Falls Service. We have prescribing pharmacists and clinical pharmacy technicians embedded in the MDTs, working to the top of their license, and we're just about to recruit pharmacy assistants to take that skill mix further. Charlie is a prescribing pharmacist working within the CRTs, and I'll hand over to her now so that you can hear about the development of a proactive approach to bone health, which was developed in the Rapid Medical Service.
Thank you. So, even on that big screen, I think that poster's still a bit small for you to see in detail, but we've got electronic copies if anybody would be interested, and we're going to talk around the poster anyway. So this poster was actually presented at the European Geriatric Medicine 2022 Congress, and was, as Amanda said, a quality improvement project that we ran within the Rapid Medical Service in Newport. So both NOG and NICE guidelines suggest that the majority of our rapid medical patients should actually be proactively assessed for their risk of fragility fracture, and this is something that we weren't routinely doing. So each bar on the poster is a random selection of patients that is then split into red patients, which are those that we could and should have assessed but didn't. The green section, which is the patients that we did proactively assess, and the grey section, which is patients that weren't appropriate for assessment. So following 2 PDSA cycles and changes in our daily practice, we increased the proportion of patients that we were proactively assessing. So the numbers, everybody likes the numbers, went from 2% to just over 69% that we were proactively assessing. We managed to make that change by including some of the FRAX questions into our CGA, so it meant that proactively assessing and FRAX calculating every patient was a much simpler job than it had been previously. Thank you.
Thanks, Charlie. Within the community resource teams, the Community Falls service in Caerphilly CRT is a consultant-led service with specialty doctor and physiotherapists involved. Bone health is proactively considered in all our patients. We often liaise with our fracture liaison colleagues. The communication is so key because we prescribe bisphosphonates, and we are aware of 1 or 2 cases within our health board where an oral bisphosphonate has been added for a patient who's already had IV zoledronate. So I think that's really something to consider when we roll these services out. With the introduction of a pharmacy technician, we have increased our bone health prescribing, and this can be seen in this poster showcasing the role of the pharmacy technician, which was presented at the Association for Pharmacy Technicians UK conference last year. The pharmacy technician undertakes checks such as calculating renal function, ordering bloods for calcium and vitamin D, and contacting patients, most importantly, to discuss bisphosphonate therapy prior then to the pharmacist prescribing. We routinely call to check on adherence after initiating bisphosphonates and proactively ask patients which formulation of calcium and vitamin D they may prefer. And I believe this in particular is the most important part, and we've talked a lot about adherence this morning and into this afternoon. I believe by doing this, we're much, much more likely to improve adherence and obviously add value. We've seen too many cupboards on home visits full of calcium supplements that patients don't take because they find them unpalatable. And yet, as a health board, and I'm sure across Wales, we are still encouraged to use the cheapest and the chalkiest. So, what about future developments? And someone alluded earlier to making every contact count. Well, within the community resource teams, we certainly can develop further by rolling out the work that Charlie and I have just mentioned. We could do that across all of the 5 boroughs that we now are about to have a pharmacy service. It also goes for all the other sectors, and we've heard people talk about, someone mentioned from Powys around needing to use GP practices more. Well, we have pharmacists in most of our GP practices, certainly in our health board. And this is really where maybe making every contact can certainly count. The real potential for me, however, has to be within the community pharmacies. And again, someone alluded to community pharmacies earlier. And I really believe that that's where we could do so much more. The many pharmacists now are qualified as independent prescribers within the community pharmacy service. And in the next few years now, all pharmacists will leave undergraduate courses as prescribers. Given the right access to patient records and links to experts, community pharmacists could well be prescribing bone health medicines. Equally, if not prescribing, community pharmacy is ideally placed to recognise those people in need of assessment and to signpost accordingly, or to follow up on adherence, and again we've talked a lot about that, and to provide the basic lifestyle advice to promote bone health. Currently, there are a lot of pressures on community pharmacy, and we really do need to resolve these first. But what a resource for early intervention and a great example of care closer to home. I'd like to finish by presenting a patient's story, and we've had a few of these, but this is a true case, a lady that our team got to know really well. Phyllis, name change, was 87 years old when she came to our service for IV antibiotic administration. She had fallen and fractured her hip, and again, we know there are a lot of those. Unfortunately, the metalwork became infected, leading to approximately 7 months in hospital and many, many more months of IV antimicrobials with us. She didn't return to her home after discharge, but moved to sheltered accommodation with care needing to be provided. We were able to deprescribe medicines related to her falls, which is really something that I believe goes hand in hand with bone health. And we liaised with the FLS around the next dose of IV zoledronate. However, for me, what Phyllis's story illustrates most is the cost to her personally and to the health and social care services, and again, we have already touched on that. Surely early assessment may have led to better bone health and prevention totally for Phyllis. Phyllis actually allowed me to photograph her and allowed me to use that photograph. Unfortunately, she died probably about a month ago. I just didn't feel it was appropriate to use her photo anymore. Thank you.
Thanks, Amanda and Charlie. I think as a GP and as my GP colleague from Powers just mentioned, the osteoporosis and rigidity fracture care in my practice is run entirely by my clinical pharmacist, and I think they are a wonderful resource. I would go on to say even better than a GP like me, and you know, to get that service going in primary care. But I can see a hand up. There's a question. If you can use the mic, we could all hear. Thank you.
Thank you, Amanda. I'm Rafia. You know me via Teams. You have not met me in person. That's why you can't recognize me. Thank you. It's been really useful to hear about how pharmacy has used their unique skills in helping the patients living with healthier bones. I guess my question is, do you feel well integrated into the wider system? If not, what barriers do you see? And if you've got any thoughts, how we can overcome them as a profession? Thanks.
I think we're incredibly privileged where we particularly sit as pharmacists. So we are well embedded in the integrated service. So we sit with all of the multidisciplinary team, from frailty consultants down to carers. All of them have access to us, and more importantly, we have access to all of them, and so we learn every day from them. I think the one thing you could say about pharmacy is that sometimes, and I've been a pharmacist in the sort of acute service, that we kind of scoot back to our nest, if you like, and therefore don't integrate totally with the full MDT. That is changing, I'm sure. And I think perhaps the challenge for us most is to get our community pharmacy colleagues more integrated, because obviously they're sitting maybe more isolated out in the high street, which is where we want them in terms of patient interaction, but of course it does isolate them.
Thank you.